great pleasure for me to introduce Dr. Kristin Labovsky. I talked about how resources can build dedicated teams, and she is the shining example of what you can do to advance the field of pediatric anesthesia, specifically for exstrophy. She is our lead anesthesiologist for our exstrophy program. She's really brought some innovations to how we do anesthetic care, and as a parent, that comes as a great reassurance to know that we're also advancing the field of anesthesia around the care of exstrophy. So, Dr. Labovsky, please.
Good morning. I think it's still morning. Can everybody hear me okay? Okay. I'm Kristin Labovsky. I'm one of the pediatric anesthesiologists at Children's Wisconsin. And as Dr. Krieger so kindly introduced me, I'm the lead for urology and bladder exstrophy here at Children's. So I'd like to thank you very much for inviting me. And I'm really excited to talk today about how we here at Children's Wisconsin have tried to create a comprehensive team to care for children that are born with bladder exstrophy. I have no disclosures to report. When a child and an infant presents for their repair, they're at a very vulnerable time in their life. They're only a few months old, they only weigh a few pounds, just a little more than a gallon of milk if we're talking in Wisconsin dairy terms. And they also have some physiologic changes, such as a lower red blood cell count that occur in the first 2 to 3 months of life. So our goals really are to take meticulous care of these children as they undergo their repair at this vulnerable time in their lives. And the goals of anesthesia in general, we want to keep your child safe and comfortable as they are asleep under general anesthesia. And these are goals for any anesthetic procedure. But there are some specific things that we are concerned about in children that are undergoing bladder exstrophy repair. And so we accomplish these goals using a lot of different tools and medications. So first up, how do we make sure that kids can go to sleep and stay asleep and be comfortable? We use medications, we use anesthesia gases, and these medications and gases allow us to turn them off and have children wake up quickly and then get on to their repair and their healing. We also use many tools to keep children safe as our second goal. We use a lot of different monitoring. We check heart rate, blood pressure, and the blood pressure we monitor every beat of the heart. We check oxygen levels, we look at the patient's temperature, and we even monitor blood flow that I'm going to talk a little bit about in a few minutes. We also are carefully monitoring all of the patient's electrolytes and blood cell counts. And our third goal of anesthesia for bladder exstrophy repair is we want to keep kids comfortable. And we do this both with medications as well as with an epidural if we can. And the epidural is, there's a picture there, it's a catheter that's placed in the back, and it bathes the nerves as they come off the spinal cord in numbing medicine and keeps kids numb at the actual site of the surgery. And we keep that in for a couple of days post-op to really help kids with pain control afterwards. So at Children's Wisconsin, we created a team to help accomplish all of these goals that I just talked about safety and comfort. And this starts before the patient even arrives to the hospital. I work with each anesthesiologist, if it's not me, to prepare for and plan each anesthetic. And at Children's Wisconsin, we do our procedures in one day. And so communication is crucial to ensure that that day proceeds smoothly. We actually exchange email plans ahead of time between all members of our perioperative team. So our surgical colleagues send out their plan, and then I'll respond with a plan of my own. And this helps to keep everybody on the same page. So all of the surgeons and the techs and the nurses and our pain team, they all know what the plan is for that day. And it also allows us to communicate any special needs that each patient may need. So during the course of developing our team, we've kind of identified several things to help us achieve all of these goals that I've been talking about safety and comfort. One of the things that we do when a child comes for bladder exstrophy is we use very careful monitoring of labs, and we take these lab values and actually calculate the body's pH and acid-base status, and that helps us guide what kind of fluid they need, how much fluid they need, if they need a blood transfusion, so that we can give them not too much, not too little, and just the right amount. We also have found that it's really important for us to ensure that these patients have durable intravenous access after surgery. And we do that by placing a special line that's long and in a large vein during the operation. And then these lines can stay in place throughout the course of the patient's hospital stay, and it really allows us to administer medications, to do blood draws, and we don't have to constantly be poking children after the procedure. And then we also use a special monitor, that special monitor for perfusion that I mentioned before, and there's a picture of it at the bottom of this slide. It's called near-infrared spectroscopy, or we call it NIRS for short. And this is a non-invasive monitor. It's just a sticker, and we put it on the head and on the back, and it allows us to monitor the blood flow and perfusion of our organs in the body. And this really helps us determine, do our patients need a blood transfusion? Do they need more fluid? Or even, do they need more pain medication? And then the third goal of our anesthesia is comfort. And this is where we really collaborate with our acute pain service colleagues. We want to make sure that that kids are comfortable after surgery. And in order to do this, we use a multimodal approach, which means that we approach pain from many different angles. We use the epidural to deliver numbing medicine so that children are comfortable. We use non-opioid pain medications like Tylenol and medications for muscle relaxation to really help minimize the use of opioid pain medications as well as sedating medications for each child. And all of this starts in the operating room. The first thing that we do when we place an epidural is we take an x-ray of exactly where that epidural is. And that helps us ensure that it's in optimal position to make sure that the children are comfortable afterwards. One of the other things we found out that we have done is we take pictures of the epidural dressing and the site, both before and after we place the spica cast and put the little hole in. And this has helped us post-operatively in many different ways. And we put these pictures in the electronic medical record so everybody can see them. So the nurses post-op, the pain team afterwards, they know exactly where that epidural is, they know exactly what dressings were used, so that they can more quickly and efficiently assess that site. We check these epidurals multiple times a day, and so by having that reference picture, our nurses and our pain team are able to make sure that the epidural is in the same spot, and so we're still getting the best pain control that we can. And also, when it's time to remove it, they know exactly what they have to take off, exactly what dressings they have, and so they can make sure that everything is completely removed. And so really, this is our ultimate goal, is what's pictured on the screen. We want a happy, healthy child that can quickly recover and heal and get back home to their family. And I often joke with families that if I've done my job right, you won't remember my name, and that's great, but I will tell you that my colleagues and I really do consider it a privilege to be able to help care for these patients as they come through surgery. So thank you very much for this opportunity.
Can you stay for 2 questions?